We are live.
Good evening, everyone. I welcome you all to today's iFocus online session. Today we have Professor Dr. Mohan Rajan sir, Head of Rajan Eye Care Institute, Chennai, to talk on complications of complications and how to manage them in phacoemulsification, and also about complex cataract surgeries. Welcome, sir.
Thank you.
Moderator for today's class is Dr. Pratiksha Sharma, ma'am. Ma'am has finished her MBBS from Lady Hardinge Medical College, MS from Maulana Azad Medical College, after which she did a senior residency from Guru Nanak Eye Center, Delhi. Currently, ma'am is the associate consultant at Center for Sight, Haryana. Previously, she has worked as specialist at ESI Hospital, Haryana. She's a recipient of Champions Award by UC, and she's a distinction. She held, achieved a distinction in medical training. Ma'am has authored over 30 journal articles and given over 40 presentations and lectures at various ophthalmic meetings, both national and international. Welcome, ma'am.
Thank you, Kritika. So welcome once again. And today we have, let me introduce my chairperson first. So we have Dr. Arvind. Kritika, can you change the slide? Yeah, thank you. So as we all know, his intelligence extends beyond academics. He has done his MBBS he has done MBBS and MS, and he is gold medalist. He has done fellowship in pediatric ophthalmology from Mahatma Eye Hospital, Nagpur. Currently, he is additional professor and head of cataract, glaucoma, practice, Quint Pediatric Ophthalmology and Medical Retina at All India Institute of Medical Sciences, Hyderabad. So his award goes to first Indian to win Ophthalmic Star Award at Amsterdam ECRS 2021, AIOS International Hero Award for year 21, 22, 23, 24, continuously for 4 years. First to receive AIOS Senior Academic Achiever Award 2021, IIRSI Gold Medal Best Innovation Best Cornea Video Free Paper Award, IFFA DOS Best Video Awards. He has conferred over 12 Oration Awards, Best Video Award and IGO Honor, Teachers of Tomorrow Best Poster Award by AIOS. More than 600 international and national presentations, 100 international national publications. He is Associate Editor of UKJOS, Section Editor IGO, Editorial Board, Member EC Ophthalmology, WJCC, IGOVS, DOS Time, and JHOS. He is International Faculties, SIC, SSO, WOC, ICO, and ESCRS. So once again, welcome, sir.
Thank
Also,
you.
we have... Thank you, sir. So today we have privilege of being in presence of the true visionary and leader in the field of ophthalmology, our guest speaker, Professor Dr. Mohan Rajan. As he himself does not need any introduction, still I'll try to brief about him. He's at Rajan Eye Care Hospital, a super specialty postgraduate institute of ophthalmology affiliated to National Board of Examination. He is specialist in both anterior and posterior surgery. He's pioneer in robotic cataract surgeries, performed more than 1.5 lakh cataract surgery, 4,000 retinal surgery, and 5,000 corneal transplantation. Made around 2,000 presentations at national and international, done more than 140 live surgeries globally. He has several innovations to his credit, including Puncho-rhexis, Mohan Rajan Chopper, etc. He has delivered 29 named orations, published 48 publications in various journals, has won several Best Videos Awards at AAO, APARS, ASCRS, ESCRS, APAO, WOC, etc. Has received Best Doctor Award twice from Government of Tamil Nadu, has trained and mentored more than 600 ophthalmologists across the world. He is winner of 80 OPL, Ophthalmic Premier League till date, which is again a world record. And the various rewards which he have received is, Kritika, can you change the slide?
Next slide, please.
One slide is there, I think I gave. Only one
So
slide.
once again, welcome, sir.
Thank you.
So let's all get ready for, he'll be sharing his insights on the topic. Welcome, sir.
Okay, shall I share my screen?
Yes, sir. Mhm.
Okay. Are you able to see my screen now?
Yes, sir.
You're able to see?
Yes, sir.
Am I audible?
Yes, sir. Mhm.
Okay. Let me at the outset thank the iFocus Center for Sight for the wonderful opportunity. My very good friend Arvind Moria, who I consider my role model. He is because he is the way he is shining in the field of ophthalmology especially in the past few years is really fantastic. And of course, Dr. Kritika and Dr. Pratiksha here from Center for Sight. And it's always a pleasure to be in the iFocus physical meeting as well as online meeting as well. Today, in the next maybe 40 minutes, I'll be talking about managing phaco complications and some complex cataract surgeries. These are my financial interests. And I consider these two people as the gold standards, Santosh Shanavar and Mahipal. As you know, the gold standards, these are I think they are always inspiring us. They always motivate us to do better and better in whatever we are doing today. And thank you very much. We are really blessed to be associated with both of them and also for the Center for Sight. As you know, the management of complications by a phaco surgeon is a difference between an ordinary surgeon and an extraordinary surgeon. An extraordinary surgeon will manage the complications and give 6/6 vision for these patients. Let us start one by one. As you know, these white cataracts, it's an intumescent white cataracts type 1. Type 2 is a mature white cataracts and type 3 is hypermature white cataracts. Among these, the type 1 intumescent white cataracts are the most dangerous.
The last capsule
Here is
in
Argentina
intermittent
flat
cataract
sign
with
is a
high
very common
intracapsular
thing.
pressure, giving
As soon as you touch the anterior capsule, the rhexis goes to the periphery and produces a typical Argentina flag sign, which can be very dangerous because the rhexis can wrap around the equator and go into the posterior capsule, and you can start losing the capsular the nucleus within no time as soon as you put the phaco probe. So once you have a rhexis tear, in this particular case, what I'm trying to do is I'm converting that one half of the rhexis into a semicircular rhexis, as you can see here. And then I don't want to have any tags there. And then again, I'm using a Vana scissors through the main port, making sure there is a good viscoat in the anterior chamber so that the anterior chamber does not become shallow. Again, on this side as well, on the right side as well, I convert that into a semicircular rhexis. And this is a fairly soft in the sense is about grade 2 to 3 cataract. So what I do is a phaco chop, a direct chop, wherein there is absolutely no stress on the bag. And I pull up the nucleus slightly up into the iris plane. And I don't mind losing some endothelial cells, but I don't want this rhexis to wrap around and go to the posterior capsule and I wrap around the equator. So now and then I put viscoat into the anterior chamber, and you can see that is a fairly not a very hard cataract we're able to do. You can use the cold phaco modulations, which are there in all the phaco machines available now. And this patient did very well with the 6/6 vision and without any problem at all. So if it's probably hard cataract, brown cataract, probably you need to convert into an SICS. But still you can go ahead provided you follow certain strict protocols. Suppose you have a type 1 intumescent cataract, you can put a 27 gauge needle underneath the anterior capsule, make a small nick and then aspirate the liquid cortex. This decompresses the front compartment of the eye. And then, of course, with a trypan blue staining, you can go ahead and do a rhexis without any problem. And this will work in about 60%, 50 to 60% of the cases. So this is not a very major issue. Of course, I'm doing all the mature cataracts, most of the mature cataracts. The patient can afford. I do this femtorhexis with using the catalyst machine. I don't have any financial interest. but makes the life easy because it's almost a foolproof method. Only thing is, you have to look for skip areas in the thing, and you can do that very well without any problem at all. And then, of course, we have the capsule laser and also the zepto laser as well.
This animation shows
see
the
here,
increased
this again-
intralenticular.
There is even an intumescent type 1 cataract. There is a pressure underneath the anterior capsule. That is a component number 1. The nucleus is bulky. The pressure in front of the posterior capsule. And there's also a positive vitreous pressure. That's why as soon as you touch the top, the nucleus comes forward and the rhexis goes to the periphery and produces an Argentina flag sign because there is a pressure. So we need to take care of all these components. And that's why I devised this technique called Puncho-rhexis way back in 2016. And I got the best video award from the APSCRS and the best paper award from the AOS as also. Wherein we go with the phaco needle and punch, give a burst of phaco, keep that in the continuous mode. And these are the parameters I use on a Stellaris Venturi system. You can use a peristaltic, but the Venturi system is better because the rise time is faster. Once you punch the anterior capsule, you can see here, go down as if you are going into the anterior vitreous and punch straight away. Once you punch it, what will happen is it decompresses the front and the back compartments within a millisecond, and there's no question of any Argentina flag sign. The fast decompression of the bag, which is again very, very important for you to understand this entire ball game. And then you can make the rhexis whatever size you want to. So first put trypan blue and then make the through the side port and make sure that you put only HPMC, no viscode because viscode can occlude the tip. Go straight down and you can see vertically down and making sure that you have got bevel down. So I use normally a 15-degree tip. You cannot use Kelman tip or a curved tip for that matter. You should use only straight tip because that can produce the maximum occlusion. And you want the maximum occlusion and also go all the way down on the foot switch. So what happens is it not only punches the anterior capsule, it decompresses, as I told you, the front and the back compartment. Same time, because you're giving phaco power as well, it debulks the nucleus and pushes the nucleus back. Otherwise, the nucleus, as I told you, is very bulky in these cases. And once you touch the anterior capsule, the nucleus, because it's bulky, you can see the phacoemulsification also, the emulsified lens on the anterior surface, which actually decompresses and pushes the nucleus back. And this makes your life easy. It's called Puncho-rhexis. Followed by this, you can do what is called a Phaco-rhexis as well. This involves a little bit of a learning curve, but they can also be done. So again, you can see here, this is another patient. I am doing a rhexis there. The rhexis is going beyond the 6 or 7 millimeter. Once it goes beyond the 6 or 7 millimeter, the zonules get attached and you can lose the rhexis. This is an escaping rhexis. So what I do is, instead of doing the rhexis in the same direction or in the opposite direction, I pull it in the same direction. This is called the Brian Little technique, rescue technique, a little technique. You can see here, I'm going from the right to the left as I'm doing the rhexis. And then instead of continuing in the left side, I'm pulling it on the same side, that is the right side. As you can see, I am pulling the thing and the rhexis is starting coming into the center. And then you can put some good OVD there, like viscoat or something like that, and then convert the rhexis into a regular rhexis. This can prevent rhexis from going into the periphery, the little rescue technique. But the most important message I want to give is that make sure that the rhexis is not very good. If it goes beyond the 6 millimeter zone, then there's a possibility of losing the rhexis, especially in a mature cataract or the type 1 mature cataract. Dense brown cataract we see very commonly in our country. And problem is, it's like a piece of granite. Always look at the endothelium, make sure there is no cornea catheta before you do the phaco. I developed this technique called the Quick Chop Express, you can see here. What I do is all these dense brown cataracts, I put the trypan blue. The reason why I put a trypan blue is because I want to see the rhexis margin. The rhexis margin has to be seen while I'm chopping these cataracts. And because I do what is called the vertical chop, I make a small trench. In this particular case, I'm using a Stellaris machine, wherein I put a high vacuum, and the aspiration flow rate cannot be adjusted separately. But the most important, I'm using my chopper, which is a Mohan Rajan chopper, which is made by Swami, which has got 1.75 and even 2 millimeter for black cataracts. This 1.75 is what I'm using. You can see I'm chopping right in front of the rhexis margin. Again, making sure that you bury the tip very nicely into the nucleus body, and making sure that good amount of sleeve or that phaco tip is exposed very nicely. And the chopper works like magic, and you can see that once you divide the cataract into smaller pieces, then you can go on the dual linear mode, which is there, the hyperpulse, which is there in all the machines now. And of course, you can use even the auxiliary technology if you're using the Centurion machine or the Infinity machine for that matter. And ellipse technology if you're using the Signature Pro and the Veritas machine, which you're using now. So this makes life easy. You can have crystal clear corneas now and then put viscoat into the anterior chamber. But if you have a corneal burn like this can be a very dangerous thing. The corneal burn can be because of a tight wound or because of excess phaco energy, or probably you are giving phaco without aspirating the viscoat which is there in the anterior chamber. You can see these corneal wounds are very difficult problem. One of the major issues is that very difficult to close as well. You have to put multiple sutures for this corneal wound, and there can be wound gaping, wound infection, endophthalmitis, intraocular inflammation, irregular astigmatism, and all these complete distortion of the cornea can occur. You can see this corneal burn, I have to put multiple sutures. I learned from Uday Devagan just last week when I was in Narayan that you have to put not only multiple sutures, radial sutures, you have to put suture like covering abutting the roof and the floor of the incision as well, apart from the radial sutures. That will make sure that otherwise it's very difficult to close these corneal wounds. And but you need to do this making sure that prevention is always better than cure. Especially the burning the cornea is one of the major problems in my opinion. Again, you can see your arcuate incision is leaking here. Anything which is wound leaking, you can see I have done a femto fairly brown cataract. Femto-rhexis has been done. And you can see that arcuate incision. Once you have a leak, please come out of the eye and put some sutures there. Make sure that the wound is, whatever leak thing is completely sutured. It's watertight. Because if you don't want that leak to occur throughout the surgery. And because of that, what will happen is the entire nucleus, especially in a brown cataract like this, you will do the phaco in the anterior chamber and you will have white cornea the next day. And another important thing is because of this thing, there can be a forward movement of the posterior capsule because the AC becomes shallow. And also you can see here, once I put the wound, 2 sutures for the arcuate incision, I am going ahead without any problem at all. And this patient also did very well with the clear cornea postoperatively. And of course, the sutures, you can always remove it after some time. And then that will take care of the astigmatism as well. Again, you can see here, if you have a limbus to limbus corneal edema, postoperatively within about 24 hours or 48 hours or whatever it is, there are two things you have to take care or you look for. One is a TAS, toxic anterior segment syndrome. The other one is a Descemet's membrane detachment. The toxic anterior segment syndrome is something you need to put the patient on topical antibiotics and steroids and systemic steroids as well. And the TAS can be because of various reasons. But you can see you do ASOCT. I'm sure everybody's got an access to an ASOCT. If you do an ASOCT, you can see here there is a Descemet membrane detachment. This is not uncommon because older patients, they can have a cornea catheta, subclinical cornea catheta, wherein the Descemets in the endothelium is a little loose. And especially when you are not hydrating properly, or when you're hydrating properly, there can be a Descemets. There can be a Descemet detachment in the main wound as you go into the thing. Or when you're using blunt instruments. So all these, you can actually overlook it. So something which is a thing, you can see here, once you have a Descemet detachment, you can see here in this particular case, this is a preoperative, that is when the Descemet detachment is there. And once I put an air bubble, you can see how the cornea is cleared up. So you can take the patient back into the theater and then inject an air bubble. In some cases, if the air bubble one or two this thing attempts you can do. Otherwise, you can put C3F8 or even SF6 for that matter. Go through the area wherein it is attached, it's a clear cornea, and then making sure that there is a total airfill. There should be a total airfill, and when you come out of the eye, making sure that the air does not escape. Then ask the patient to lie down flat in the operation theater itself for about 15 minutes. You can see a gradual clearing of the cornea. And once you go clearing of the cornea, you can release a little air bubble because you don't want a pupillary block and increase in the intraocular pressure. And most of these detachments, they do very well with an air injection, provided you do it properly, but identification is very important. Identification during the surgery, suppose suddenly half the Descemet comes out, then always put viscoat and make sure that you identify this Descemet detachment intraoperatively, and so that you don't chew up the Descemets during the phacoemulsification procedure. So Descemet detachment is more common than what you can imagine. Only thing is you need to be aware of this problem, especially in older patients and patients who got cornea cataracts and fuchs endothelial dystrophy, wherein the Descemet is loosely attached. Again, posterior polar cataract, the problems is, as you know, there is an increased incidence of PCR. It's not actually PCR, it's a congenital dehiscence of the posterior capsule. Increase in the nucleus drop, there's a plaque in the posterior capsule as well. So you can see one of the, if you have a mature cataract in one eye, you do not know whether it's a posterior. Look at the fellow eye. If the fellow eye has got an ACIOL lens in the sulcus, or a iris claw lens, or a glued IOL, or something like that, it always gives an indication there's a possibility of a posterior polar cataract in this particular case. So you can see here in this posterior polar cataract, there's a little older patient, and actually he's an ophthalmologist from one part of Tamil Nadu here, and he was referred to me and he by another ophthalmologist. And see, as I'm doing a rhexis, always make sure the rhexis is not very big, not very small, about 5 millimeter, because you want to do the optic capture. If it's very large, very difficult to do optic capture. I can see that I'm doing what is called a slow motion technique and trying to aspirate that nucleus and epinucleus. I'm not attempting to rotate the nucleus. As I'm removing the epinucleus, you can see what is happening. There is a huge dehiscence in the posterior capsule. It's a very typical of a PPC, wherein it's like two pillars on the posterior capsule. It's not like a PC tear. So once you do that, you can see that immediately inject viscoat and immediately switch over to the bimanual technique. Always put tricot there and delineate the vitreous and remove the vitreous first and then remove. Every time you come out of the eye, inject viscoat there, because the viscoat can go and plug and act as a nice scaffold and remain in that area for quite some time. I can see here I'm remove the vitreous and I'm trying to remove the cortex and trying interchanging. I'm not using the main port at all, because if you use the main port, there can be a shallowing of the anterior chamber. I will go through the side ports, create right port. You can see the typical two pillars on the posterior capsule. You can't put a single piece lens in the bag, because sometimes you can, most of the times you can go into the retina the next day. Always put a multi-piece lens, a 3-piece lens. In this case, I'm putting an MA60 Alcon lens, but I don't have any financial interest. So just to show you that how the haptic of the lens is going into the sulcus. And then don't leave it in the sulcus. Most important thing is, if you put the haptic in the sulcus, the optic is captured into the bag. Okay, this is called the optic capture. So you lock the lens and leave the lens. You lock it, leave it, and forget it. So that I think that's a message, because once you lock the lens, it's as good as the lens in the bag. You don't have to adjust the power or anything like that. So the haptic is in the sulcus. The optic goes into the bag. The end point is the visualization, or the ovalization of the anterior capsular rhexis, that is the margin. You can see the ovalization. It means that the lens is well locked here. If you leave it locked, this lens will not move a micron, and you don't have any EGH syndrome. You can see here 2 months, 6 months, 6 years, the lens is quite stable without any problem at all. Again, most of these cases of PPC, I do because I have access to the catalyst. Because the advantage of MyPal has also shown in this beautiful publication how the intraoperative control is much better with the femto. Because in femto, the rhexis is already done, the segmentation is already done, You don't just have to go and pick it up. And every time you come out of the eye, you inject visco into the eye. Whatever visco you're having, preferably hyaluron or whatever it is. But even HPMC is good enough. You can just have to inject. Don't allow the chamber to shallow, because chamber is shallowing, and you can have a forward movement of the posterior capsule and opening up of the posterior capsule in a posterior polar cataract. So always stabilize the anterior chamber if you come. This is a plaque which is there in the posterior capsule. And it's very difficult to yak these plaques. So I try to remove it. I'm using something like a bimanual technique. This is an young girl and with a unilateral posterior polar cataract. And I removed the plaque. This is called the plaquectomy, and which can be done without damaging the posterior capsule. I put a symphony lens in this patient, and patient had fairly good 6/9 N6 vision post-operatively as well. This is also possible, can do, but only thing is you have to be a little careful about it. These are the pearls when you do the posterior polar cataract. I do always peribulbar or parabulbar anesthesia or subtenon anesthesia. Rex is about 5 or 5.25. Oval rhexis has been advocated by Kiranjit Singh. I don't do that, but it's a very good technique. Hydrodelineation, femtodelineation, if you're going to use a Lensex machine or any femto machine for that matter. Slow motion phaco, low flow parameters, reduce the vacuum, reduce the flow rate, reduce the bottle height, and do not attempt to rotate the nucleus. Inject viscoelastic every time you come out of the eye. Bimanual IA is always better because bimanual IA gives you better control. Phaco in pseudoexfoliation, again problems. You can have small pupil, zonal dialysis, PCR, secondary glaucoma, increased postoperative inflammation, cystoid macular edema, and late subluxation, dislocation, as you can see in this particular picture. This can also occur in pseudoexfoliation, especially when the rhexis is a little small. There can be progressive phimosis. As you know, pseudoexfoliation is a progressive zonulopathy. And because of that progressive phimosis, what will happen is start pulling the zonules. The entire lens IOL complex, the back complex can go into the thing. Again, you can see here, this is a small, it's a mature cataract, pseudoexfoliation. And these patients, as you know, they don't dilate well also. I'm going ahead and doing a rhexis. Doing a rhexis in a small pupil, so always make the rhexis slightly bigger than the size of the pupil. In this, you cannot do it with the needle. Always use a rhexis forceps if you want to do it, because you have better control. Follow the margin of the rhexis underneath the pupil. This is not a very, very hard cataract, so I thought I'll go ahead without any pupil expanders, which is not actually a great idea. So once you have a small pupil and also pseudoexfoliation like this, it's a thing. I just want to show you this, that it's also possible. And this is the old video at the time when we didn't have much of the thing. Of the iris hooks and other retractors at that time. So I thought I will do this as well. But only thing is, I'm making sure that the whole thing is going on very well. I'm making sure I'm making the what you call nucleus into smaller pieces, and I'm making sure that I'm not going anywhere near the iris. Always use an Y retractor to find out if there is a small nucleus piece or any cortex underneath the thing, and always make sure that this rhexis, which is small, in this case there is a small zonal thing. I put a CTR in this particular patient and went ahead with the thing. Acute intraoperative rock-hard eye syndrome, AIRES, is not uncommon in pseudoexfoliation, and also high myopia as well. In pseudoexfoliation, more common because of the zonulopathy or the zonular dialysis or the zonular weakness. And through the zonules, what will happen is the fluid can go, the irrigation can go through the zonule, hydrate the vitreous, and there can be sudden increase in the positive pressure. And the posterior capsule can come forward, the OVD will come out, the lens will come out, and all this, and the iris will start coming out. Marked increase in the IOP, no choroidal hemorrhage, effusion, inability to inject the OVDs or the IOL. Iris spontaneous extrusion of OVD, resistance IOL implantation is something we need to be very, very careful. Always look for. If you have leucing, and we can always put a trocar and cannula into the vitreous cavity and do what is called a limited vitrectomy. You know, this IFIS is not a very, very not uncommon. Nowadays, with patients living older, and many of the patients are on tamsulosin, like Urimax or Flomax or whatever it is. And you can see this iris, and you need to have a careful history and make sure that if the patient has got this the tamsulosin and the pupil, my cutoff is about 6 millimeter. If less than 6 millimeter, then I always go right in the this thing. You can see here. And because of the IFIS, this is a long time back, this video was done. At that time, we didn't even know there was something like an IFIS. And you can see I'm doing what something like a phaco technique. And you can see the whole iris is coming forward because of the small pupil. And we didn't even realize at that time, but this can happen if you don't dilate the pupil in IFIS, because there can be progressive meiosis. And this is one of the common issues. And you tear the iris, you can produce iridodialysis, bleeding can occur, you can produce PCR, and all the problems can occur. Again, this is a femto. You can see I'm doing the thing. Femto cataract, the rhexis is done, the softening of the cataract is done. So as I am removing this thing, you can see the iris is coming out of there. You can see, make sure that you don't overfill the viscoelastic. I'm just putting gently viscoat there. I always use viscoat. Viscoat is something which is, don't use HPMC when you have IFIS. You always use viscoat. You can see here. So as soon as I put the viscoat, you can see this is not the correct way. Always go through a side port. Then immediately what I do is, I know this is a fairly hard cataract. I can't do this with this pupil. And because this pupil is going to become smaller and smaller progressively. And I immediately put iris hooks and went ahead with this particular case without any problem at all. So this take-home message is either put iris hooks or a Maligan ring or a BX ring, whatever you're comfortable is. Posterior capsule rupture, anticipate PCR in a traumatic cataract, post-vitrectomized eye, posterior polar cataract, hard brown cataract, pseudoexfoliation. And nowadays we have patients who have got a lot of multiple injections of Avastin or Accentrix into the eye. And these are the patients that can be a lens touch. And because of that, you can see, and I'm doing what is called an hydrodissection. What is the mistake I'm doing? I'm doing hydrodissection. Every time you do a hydrodissection, you need to decompress the nucleus back into the back. But I'm continuing the hydrodissection. You can see here what is happening. And there is a hydro rupture of the anterior capsule. The anterior capsule has given way. So what will happen is 100% this anterior capsule which has given way will wrap around the equator and go to the posterior capsule. And as soon as I put the phaco probe, there's a possibility of the nucleus dropping into the vitreous cavity. So something which is very, very important, look for the pupillary snap sign, which has been described by Ronald Yu. And again, very, very important for you to understand. So every time, especially when you're doing multiple cotton hydrodissection, go in and do a hydrodissection, decompress the nucleus. You don't want the pressure to go increase between the nucleus and the posterior capsule and produce what is called a capsular blowout or a hydro rupture for that matter. When you have PCR, okay, and this is just to show animation for you to show, if you use coaxial irrigation aspiration, coaxial means the irrigation and aspiration are in the same port. If you use coaxial, what will happen is the PCR will become more, and the more vitreous will start coming into the anterior chamber. So the vitreous is like a tsunami. So if you open up the PCR, more vitreous will get hydrated and come. But if you have bimanual means the irrigation is separated from the aspiration. The irrigation is separated by means of an anterior chamber maintainer or a separate irrigation port for that matter. Then aspiration is separated or the cutter is separated. Then it tampons the PC break and prevents the hydration of the vitreous, which is again, and whatever vitreous is there, and the PC tear does not enlarge if you do see. That's why when you have PCR, don't pull out of the eye is very important. You can see here, one of my phaco trainees, you can see here he's trying to do a phaco and cortical aspiration. But you can see that the mistake he's doing is trying to catch the posterior end of the cortical fiber. He doesn't even realize there is a PC tear and the nucleus is also going back. But more importantly, he pulls out of the eye. When you pull out of the eye suddenly, what is a small PC tear will become a huge PC tear and more vitreous will start coming. Immediately I go into the, use a bimanual IA. At that time, it was only 20 gauge cutters are available. Nowadays, 23 and 25 gauges are available to us. And I go in and fortunately for me, as I remove the vitreous, as I told you, the nucleus comes up a little and then I support that with the irrigation and then use the phaco to remove it. So always remove the vitreous first and then remove the cortex and the epinucleus. And obviously this patient, you cannot put a single piece lens in the sulcus because rhexis margin is intact. So always put a multi-piece lens in the sulcus, and in this patient also did very well. So do not pull out is very important. So if there's a small PC tear, you can see here as I'm removing the last nucleus piece because of the post-occlusion surge, which was there in this was a old machine, a second generation universal 2 machine, if I remember right, I was using that. But what I'm trying to think, I don't lose my calm. So when I see the PC tear, it's a very small one there, but just like a posterior rhexis. But I inject viscoat. Can you see that? I'm injecting viscoat. The viscoat will go there through the side port and gently withdraw the phaco handpiece. So I'm stabilizing the anterior chamber. The viscoat will go and plug the PC tear and stay there forever. So that is the advantage. Immediately shift to the bimanual technique. And because the anterior, as I told you, the bimanual, wherein the irrigation is separate from the aspiration, it maintains the tampons the PC tear and prevents hydration. But in this particular case, I was able to put a lens in the sulcus. Again, another patient with the posterior polar cataract. As I'm trying to remove the thing, the the epinucleus. You can see the plaque on the epinucleus as well. And there's a PC tear. Immediately I inject viscoat there. Immediately I put tricot. Diluted tricot 1:3 is something which is very, very important because even God cannot see vitreous which is there in the anterior chamber without tricot. Again, use a bimanual technique, remove the vitreous first. Don't be in a hurry to remove the epinucleus or the nucleus for that matter. Always remove the vitreous which is there in the anterior. You can use, suppose the nucleus is there, you can use an IOL scaffold, which I'm going to show you a little later. Small PC tears like this, you can convert into a posterior capsulorhexis. Why you want to convert into posterior? Because the posterior capsulorhexis is as strong as the anterior capsulorhexis. And if you have a PC tear and if you try to put a lens in the bag, without converting into a posterior capsulorhexis, it can extend. And you can actually lose the lens into the vitreous, into the vitreous. So what I'm doing, I'm just converting that into posterior capsulorhexis. And then going ahead, in this particular case, I put an in-focus lens into the bag without any problem. So once you convert into a posterior capsule, you don't have to bother about the extension of the posterior capsulorhexis at all. In this case, very comfortably, I was able to put the lens in the bag and the patient did very well. Again, a patient who had a femto PCR, you can see here the particular case, I'm doing the thing. The reason why I'm showing is that because the hydro rupture, the thing is occurred. But more importantly, when the PC tear occurs, normally what happens? The nucleus, the pupil becomes very small. So because a lot of prostaglandins are released into the eye, immediately put iris hooks. Immediately put iris hooks and to make sure that you see the sulcus very clearly. You see the periphery before you put the lens. Sometimes if you have a small pupil and a PC tear, you do not know whether the haptic is going in front of the rhexis margin or behind the rhexis margin, or one of the haptics can go in front and another haptic can go. So always put iris hooks to find out exactly where your sulcus, where your lens is sitting, and then go ahead. Otherwise, there's a possibility of a lens getting displaced into the vitreous cavity the very next day. Nucleus drop, as you know, the nightmare for phaco surgeons, incidence is 1.1%. These are the predisposing factors: posterior polar cataracts, hydro rupture, small rhexis, and a big nucleus, and especially in the brown cataract, capsular rhexis tear, and posterior capsular rent. Again, you can see this is a nucleus drop, very hard cataract, probably hydro rupture. My assistant puts viscoelastic on the cornea, and the nucleus goes back. Okay. Only thing is, when you have a nucleus which is going back like this into the vitreous cavity, don't chase with the phaco probe. Once you chase with the phaco probe, what will happen is you can produce giant retinal tears and also medico-legal implications. So always come out of the eye, clean up the anterior segment, do the anterior vitrectomy, clean the anterior segment. And if it's a very brown cataract, I would not suggest. Of course, we have got fantastic fragmentomes now. You can see this is again posterior polar cataract, which we didn't even recognize the posterior. It went inside, and then again another patient you can see here. But more importantly, once it goes inside, then you need to go a pars plana route. Okay, you can see here I'm doing a pars plana. I'm putting 3 ports sclerotomy and then clearing up the anterior segment. And you can use the cut IA mode or the IA cut mode, which is there in the vitrectomy probe, and then making sure that the cutter is used and the vitrectomy cutter is used the nucleus is made mobile. You have to induce a PVD and your nucleus is made mobile. I'm using the same sleeveless phaco needle like a fragmentome. I'm bringing it up. This is a fairly soft cataract. Bringing up in the anterior chamber. At that time, we didn't have the IOL scaffold technique, which is a very, very useful technique, which has been described by Amar Agarwal. And this patient also did very well. Again, this is again a patient with the posterior polar cataract with the femto. You can see here, I'm doing all this. As I told you, the femto is one thing which is I do for all my posterior polar cataracts. So as I'm doing the posterior polar thing, you can see here, I removed half the nucleus, but so you can see the plaque in the posterior capsule. Little did I realize, because the OCT on the femto machine also didn't show me there was a posterior capsule dehiscence, but I was expecting this in this particular case, and this patient had also a little older patient and had a fairly dense cataract as well. You can see here it goes down. Once I remove the thing, the nucleus goes down. I didn't try to chase it. Immediately I put tricot and cleaned up the anterior segment. You can see the nucleus which is there, the half of the nucleus which is there in the posterior segment or in the vitreous cavity. I'm removing the vitreous. I put tricot there and remove the vitreous, and then again using bimanual technique, remove the cortex. You can see the capsule-rhexis is intact, but only problem, the capsule-rhexis is a little large, but whatever it is, I went ahead and put a Orolab multi-piece lens into the sulcus without any problem, and then went in with the 3-port pars plana sclerotomy in the same sitting and removed the nucleus from the posterior segment. And this patient had 6/6 vision postoperatively. Again, another patient, we got the old patient, and with the cardiomyopathy, and the nucleus is not gone in fully. Then I do what is called an anterior assisted levitation. I just put there anterior levitation and bring it up into the anterior chamber. And just like you deliver a SICS nucleus, similarly, I immediately put anterior chamber maintainer, put tricot, again the same protocols, bimanual anterior vitrectomy, and remove the vitreous which is there. In this particular case, I put an AC IOL. And this was done a few years back, and because I didn't want this patient, old patient, and she had difficulty in even getting the, what do you call, lying down for a long time. I just put an AC IOL. Only thing is AC IOL is fairly good. Make sure the corneal endothelium is good. Sizing of the lens is very important. Make sure the pupil is round. There's no vitreous in the anterior chamber. And don't forget to do an iridectomy postoperatively. I'm sorry, intraoperatively. And you can see this postoperative picture, 6/9 of this particular patient. And this patient also did very well. So there is some role for the anterior chamber oil. Only thing is, you need to make sure that you know the limitations of the anterior chamber. Only old patients, if the cornea is not sick or something like that, you can still. So again, one of my postgraduates, so what she's trying to do is an hypermature cataract with a pseudoexfoliation. What she's trying to do, she's trying to do an extra capsular cataract extraction. But whatever she's trying to do, there is wherever you need to do expression, she's doing counter expression. And wherever you have to do counter expression, she's doing the expression. So it's just the opposite what she's doing. So what is happening? The lens is slowly sinking into the vitreous cavity. But still I see the lens there in the anterior vitreous. It's not gone into the vitreous cavity. So I do what is called a posterior assisted levitation. 3.5 millimeter from the limbus, I measure and then put a sclerotomy and then introduce a rod and then go inside and bring up the nucleus into the anterior chamber. You can see bring up the nucleus in the anterior. Only thing is, this can be done in a little older patients. Don't do it in younger patients. Don't do it in high myopes. And all these patients, whether you do the anterior levitation or posterior levitation or nucleus drop or the PCR for that matter, make sure that you follow up these patients very carefully. Look at the retinal periphery, dilate and have a good indirect ophthalmoscopy examination, because these patients are more prone for retinal breaks, retinal detachment in the postoperative period. Again, this is a patient who had a shuttlecock injury and a traumatic subluxated cataract. As you know, the biggest problem in the subluxated cataract is doing the rhexis, because there is no peripheral resistance for the rhexis. So once I did it, you can see here, I put a CTR in this particular case and then went ahead with the phacoemulsification. And then as I'm doing that phacoemulsification, you can see that the lens is trying to be wobbly. So I put iris hooks. Only thing is, you can use iris hooks for the capsulorhexis. The problem is capsular hooks are always better. But the problem is the iris hooks are resting on the capsulorhexis margin. You need to basically look at this iris hook, which is on the left side, upper one. So because if you have the thing, it starts, it's resting on the rhexis margin, it cuts the rhexis margin, and because of that, the rhexis extends to the back. So there is a CTR here. It's very difficult to remove the cortex because the CTR, the cortex gets trapped by the CTR, and you need to go in a circumferential manner. You can see how the rhexis got cut because of the iris hooks. So don't have the iris hooks for too long if you're going to use it for the capsular rhexis margin. In this particular case, I did an anti-vitrectomy. I put a multi-piece lens into the sulcus and then went ahead and did a pars plana vitrectomy, anti-vitrectomy. Pars plana, which has been advocated by Abhay Vaswada's group, is more. The only thing is you need to know how to put a trocar and cannula into the vitreous cavity. You can have an anterior chamber maintainer, and it makes more sense to remove the vitreous from behind than from front because there's no traction thing, and you remove less of the vitreous cavity, this thing. Again, you can see a Morgagian cataract. The Morgagian cataract, what is the biggest problem? In Morgagian cataract, doing the rhexis itself is a problem because the rhexis has no support. And also there is a universal zonulopathy. And zonulopathy, the 360-degree zonular weakness, very difficult to do thing. And also because the nucleus is very small, it moves around in the bag, and there is no support for the capsular rhexis. So what I'm trying to do is I'm trying to do a phaco. I can see phaco also is very difficult because the capsule bag is totally lax, and also the nucleus is also wobbly. So what I do is once I remove that half of the cataract, I bring that cataract or the nucleus up into the anterior chamber, and I put a single piece Acrisoft lens, whatever lens, doesn't make a difference, but into the bag here. You can see how small my rhexis is, because if you make a larger exercise, I told you can go into the periphery. So you can see I'm putting a lens into the bag while the nucleus is still there in the anterior chamber. Viscoat and the Halon, that is soft shell technique, is very important. So once I put the rhexis, I think now my capsular bag is well stretched by means of the IOL there, and it doesn't move around there. And once I was saying, I remove this nucleus, making sure that I don't remove the nucleus very close to the endothelium and keep it slightly in the iris plane or slightly in the posterior chamber, and rest is so easy about this. So I will not go through this thing. Again, you can see another patient, shuttlecock injury, right eye 20. This shuttlecock injuries is one of the worst things. So what I do is in this patient, you can see how the lens is moving around. So the advantage of the femtocataract is that the rhexis is done, and you can see even in a mature cataract, the catalyst penetrates there. You can see the segmentation, the octants, the 8 segmentations or the fragmentation of the nucleus as well. And one side you see the rhexis is there, and then immediately I put, because there's a localized zonular dialysis in this particular case, I put the iris hooks. Only thing is, don't keep the iris hooks for too long and you don't have too much of traction. In this particular case, I was able to do it. The advantage of the femto is that because the rhexis is very easy, the most challenging problem in a subluxated cataract is the rhexis. And once you can see the direct chop, already it's pre-chopped for me, and it makes my life easy. And I don't even rotate the nucleus. I just bring it up, and it's already there. And all the pieces just run into the phaco probe without any problem at all. The patient also had traumatic mydriasis. So what I did was, in this particular case, especially when you have zonular dialysis or even patients who got severe pseudoexfoliation, what I do is I put a multi-piece lens in the sulcus and capture it in the bag, as I showed you in the thing. And even if the thing, because this is the technique which has been shown by David Chang, wherein you put a CTR in the bag and then put a multi-piece lens in the sulcus and then capture the optic into the bag. Optic capture you do. You find out that these lenses are very stable, and the incidence of pseudophacodonosis is very, very less when compared to a lens in the bag, especially when you have a zonular dialysis or a pseudoexfoliation. And pseudoexfoliation, a traumatic zonular dialysis is not as bad because that is not going to progress. But a pseudoexfoliation is going to progress further throughout the lifetime of the patient. And you can see here what I'm doing is I'm putting the lens haptic into the sulcus and capturing it in the back, I should say. The traumatic mydriasis, what you do, don't leave it like that. because this is going to produce more fuel to the flame, and the patient will be very unhappy if you leave the pupil, which is about 7 millimeter dilated. So you can do what is called the single pass 4-throw pupilloplasty, again advocated by Amar Agarwal. Very simple technique. Only thing is you have to do it 2 or 3 times to make sure you can see at the end of the surgery. Multiple passes can be done. It's very easy technique. With a 9-0 or a 10-0 Prolene, you can use that, and very nicely you can do that. At the end of the surgery, you can see here how these Purkinje images are coming into the center. And this patient, even now, is about 4 years now, and the patient is doing extremely well with a 6-6 parts N6 vision, best corrector vision. Again, zonal dialysis is something which you have to be very, very careful. And this can occur during the cortical washup. And at that time, you are a little complacent. You are not very concentrating much because you would have done a heroic phacoemulsification. You can see what I'm doing is I'm trying to aspirate that thing. You can see how the zonules are coming there all the way into the center. I don't even realize that it is coming to the center. Now I realize it's there and the cortical thing is there. And now and then I put visco, preferably Hyalon, okay? Hyalon or sodium hyaluronate, because that will expand the bag. Once you put the Hyalon and put the CTR, it makes the life easy. And once you put the CTR, the bag will go back. And you can go ahead and putting a lens in the bag without any single piece lens in the bag. Again, this is a patient who has got an hydrophilic Rayner type of lens. And you can see these hydrophilic lenses are very slippery. And the mistake I'm doing in this particular case is a traumatic. Because of trauma, there is a tennis ball injury. The lens started subluxated and decentered as well and dangling in the vitreous cavity. So I went ahead. I thought I will I'll put a 9-0 Prolene and suture that area. The problem is in these type of Rayner type lenses, a single piece hydrophilic, they're very slippery, very difficult to suture it, and which I didn't even realize at that point of time. So I tried to suture this technique, suture this lens into the, fix this lens into the sclera, but you can see the whole lens is going back south. You can see here, the whole lens is going back. And immediately what I do is I do what is called an anterior assisted levitation of the intraocular lens in this particular case. So I do a bimanual taking. All these cases use micro forceps, which is available with all the companies, Epsilon and other companies, micro forceps, and bring that lens along with the bag and outside. And then, of course, you need to take care of the anterior vitreous and then put a groove there and put a glued IOL in this particular cases without any problem. And then this patient also did very well. And you can see it. IOL exchange, you can see this patient had a wrong IOL instead of 16 diopter. She had a 28 diopter Technis lens, and we had to exchange the IOL within 1 week after the surgery. So what I do is when I bring these lenses up, okay, I don't cut it, because when I cut the lens without there can be a damage to the posterior capsule. And this I don't want that, because once you have damaged the posterior capsule, the whole battle is lost. So what I do is I put a 16 diopter MI60 lens into the bag, and this acts as a nice scaffold for me. And then I put that into the bag. Now I put a lot of viscoelastics and then cut this what do you call the lens into 2 or 3 pieces, and then without enlarging the incision, I went ahead. Now I am very safe because I already have an IOL in the bag, and the IOL acts as a scaffold. There is no fear of rupturing the posterior capsule, which is again very important. So the IOL scaffold is also a very important thing. This is something which is very, very common, especially when you are using the green injector. What happens is I'm putting an InFocus, nothing wrong with the lens. The problem is the trailing haptic gets caught because there's very little space between the silicon this thing and the cartridge wall. So what if we try to pull that lens out, it will cut and you have to enlarge the incision, take out the lens. Just use a simple, what you call as 11 blade, and open up the cartridge. This is called the episotomy, and it's called the ocular episotomy, which has been very, very beautifully described by all of us. And you can see here how it opens up the cartridge, and without any damage to the trailing haptic, the lens has gone into the back. So take-home messages, phaco complications, prevention, recognition, management, all these can produce optimal results, which are very, very important. And you can make the patient very happy. As J.R.D. Tata said, strive for perfection and you will reach excellence. Thank you very much. Don't worry. Be happy. So your adrenaline will start flowing, especially when you're operating in a complication, especially when you're operating on a VAP or a doctor or something like that. But you should stay calm and making sure take a couple of breaths and take back and sit back and relax. And if you're an agitated frame of mind, then you can produce more complications, and the complication can worsen. So sit back, relax, and enjoy your phacoemulsification. Complications are likely to occur whether you have done 1,000 surgeries, 10,000 surgeries, 20,000 surgeries, or 30,000. It can occur. For me, the nucleus drop occurred after my 4,000th case, way back in 96, 97, or whatever it is. So I want this is something for all the postgraduates and even for the practicing ophthalmologists. If you email to me, send your full address and your phone number at drmohanrajan@gmail.com. I'll be able to send one color atlas of the retina and optic nerve. It is now available in the Russian language also. And of course, color atlas of cornea, which has been done by Sujata. Thank you very much for the wonderful opportunity and the patient attention. And it's always a pleasure to be in iFocus. And I love the meetings, especially the couple of months back, we had a fantastic meeting in Hyderabad as well.
Thank you so very much, sir, for such excellent videos, surgical videos, and their management. It was really a treat to watch. Always a treat to watch.
Thank you. Thank you so much.
Dr. Pratiksha, questions for me or sir?
Yes, sir, definitely. Krutika?
Yeah.
Yes, ma'am. So in one of the surgical videos that was shown, you placed a CTR in the bag and the 3-piece IOL was placed in sulcus with
Yes.
a capsule. So why not in the bag, though it was a traumatic cataract and not a progressive?
Absolutely. You could have done that also. You could have done that also. But I find that this particular thing, because I found that the zonal dialysis is a little more. So if you put the lens in the sulcus and capture it in the bag, the long-term stability is much better. More than the traumatic cataract, as I told you, in pseudoexfoliation, extensive pseudoexfoliation, I do this on a routine basis. Because pseudoexfoliation is probably more dangerous than the traumatic cataract. Okay, because there can be progressive zonulopathy, and especially when your rhexis is a little small, there can be phimosis and start pulling it. So if you have a lens in the sulcus and optic capture in the bag, the bag will not contract. Of course, the bag is now expanded by means of the CTR already you have put. It's a technique which I have learned from David Chang. It works very well. Yeah.
So there was one more question. In case in OR, if we have two lenses available, like we have iris claw and we have 3-piece IOL, and it is a case of pseudo-exfoliation where PCR has been noted, which lenses would you prefer, sir?
I think whatever you are comfortable. Even iris claw lenses are very, very important, very good, because it's very quick and not much of a learning curve. If you want to put a scleral fixation, you have to take the flaps, and it takes a little more time as well. So the iris claw lenses are fantastic. Whether you are putting iris claw lenses or a scleral fixation lenses, either suture or a scleral tuck or a glued IOL or whatever it is, make sure that you remove the vitreous which is there in the anterior chamber in the pupillary area, and remove all the capsular and cortical remnants also. You don't want that any of those things to be there. Make sure that the pupil is round. Okay, use a tricot. Even if the pupil can be round, but still sometimes there can be a fibril of vitreous. So unless you use tricot, make sure that everything is there, and then you can follow whatever lens, whether you want. Only thing is, don't put the iris claw in the front of the iris. Always put behind. It's called retro iris claw. Yeah.
Needs to be retropupillary, and in the middle, this stroma of the
Middle
iris.
stroma. Yes,
Because
absolutely.
otherwise there will be cat's eye, that sort of picture.
Absolutely.
Post-op.
Yeah. Yeah, of course, there is a small learning curve, everything. But if you're whatever you're comfortable in your thing, and if if you're not very, you can leave them even affecting. And after a couple of weeks, you can take them again. You can probably sit them, analyze them on the slit lamp. I've done that very rarely for some patients as well. Leave them aphakic for a thing and then find out. Sometimes there can be a capsular, what you call fibrosis can occur. You can put a lens in the sulcus. Because at that point of time, you are not in the proper frame of mind. Sometimes, many times, to decide. And though you have a plan A, B, C, but you can leave them aphakic also, and after a couple of weeks, you can take them again for your secondary IOL implantation.
Is there any preference of you for placement of CTR, sir? During which step of surgery? Is there any preference as such?
I try to put the CTR as late as possible. As late as possible. I support the bag either by the capsular hooks or by the iris hooks for that matter. And I say I'd push the CTR as late as possible. And yeah, because I don't want the problem. Once you put the CTR early, okay, you can the entire cortex can get trapped, and it can be very tricky to remove this cortex also. But don't hesitate to. For example, if you're able to, if your bag is not getting stretched by the iris hooks or the capsular hooks, then you put a CTR at that point of time. So you take it by the case-to-case basis. In intraoperatively, you need to find out what exactly is happening. But I would generally put as late as possible. Generally put. The very rare instances wherein I had to put early, for example, the case I showed you, subluxated cataract, because the lens was a little wobbly in the beginning. So I had to put that lens because I don't, if you put a CTR in the beginning, there is a circumferential stability. And then you can also put iris hooks and capsular hooks that will take care of the radial stability as well. What do you do, Arvind?
Yes, sir, I agree with you. Totally agree with you. I delay as long as possible. And the capsular hook, they works very well. And then we can put.
Yeah.
And now coming to my experience with dealing with, because I am also operating a lot of these white hypermature intermittent cataracts. So instead of giving mannitol or Dimox to these patients, because these mannitol, even after 300 ml IV and to Dimox stat half an hour or 45 minutes prior to surgery, it reduces this posterior vitreous volume only up to 7%. So I'm using pinky ball and it reduces vitreous volume up to 25%.
Yes, yes.
And then I'm using Mohan Rajan chopper to make a microcapsulorhexis. I had operated more than 150 cases and not a single patient extension is noted. So
amazing.
Choppers gifted by Mohan Rajan sir. Thank you so very much. So what is happening when we are trying to make an opening with the cystitome? So if you see, with the help of the cystitome, there are two irregular opening, right? So what we are using like a sieving needle, na? Mohan Rajan chopper is very round and regular and very sharp tip, the sharp chopper. So our mothers and our grandmothers, they are using that sieving needle, right? For threading. So there is always a regular opening. So I'm trying to create a microcapsulorhexis and then we are enlarging it. And it's working very well. The clinical trial is about to be published very soon. All thanks to Mohan Rajan sir.
No, it's very nice actually. Glad that because you can do what is called double rhexis.
Yeah.
Try to make a small rhexis and then decompress the bag a little, and you can use either IA or you can use even Simcoe to decompress the bag. And sometimes I make a small rhexis and then I use even a Phaco. The thing is slight trench I do, and then debulk the nucleus a little, and then sit back and you can enlarge the rhexis to whatever size you want.
And coming to the Morgangian cataract, my experience is it's very difficult to grasp. Even the rhexis is difficult. So we are using this Uttarata forceps or this microcapsulorhexis forceps. And it works very well. And now the problem is regarding the holding. So we are pushing the visco-OVD behind the nucleus. So it comes anteriorly. And then we are using this blunt olive tip terminator chopper to hold it. And then we are using this phaco, and it's worked very well.
Yeah, yeah. I think it was very important because in the Morgan cataract, the problem is you cannot trench.
Yeah, it's holding.
So what I do is I go bevel down, I go straight into the center of the nucleus, nicely bury it nicely into it, and then because the nucleus is not very big, it's a little smaller only. You can actually chop from the periphery. You
Yeah,
can see the
peripheral
equal
chopping is the
chop
best
of the
technique.
periphery. And
Yes.
something like horizontal chop you do, and
Yeah.
then or a tangential chop, you can do that as well without any problem at all. But only thing is the bag is wobbly, and the bag is
Yeah.
lax, so it moves around. So that is the
Yeah.
reason why I want to put an IOL scaffold there and stabilize that bag. It makes your life easy.
Much easier.
Yes.
And now coming to that one case you shown, sir, that dangling that IOL.
Yes.
So we are using, since the Dr. Sergio Canabreva introduced this technique of 3 and 4 flange technique, sutureless technique. So we are using 70 proline, and we are stabilizing it using the 3 or 4 flange of this
Yeah.
proline suture through the sclera and through the optic and the optic haptic junction at 90-degree differences, and it works, stabilizes any type of PCIOL. So we
No,
don't need to go for
yeah,
SFIOL or the retropupillary iris claw, anything. It's not
fantastic.
at all required.
Yeah, the flange technique is there.
Yeah, yeah.
Problem is in the Rayner type of lens, the hydrophilic lenses, they are a little slippery.
Yeah.
Sometimes, the haptic is not getting engaged, but still you can do it. The flange technique can do that.
Yeah, suture is passed through the 26 and
Single
half.
single piece Acrysoft lenses and all we have fixed very nicely.
Yeah.
It's something which I just want to show because see, we have to show the complications.
Yes, of course.
Not the regular patients. Everybody is doing the regular one. I have to
Yeah,
show the complications. What are the mistakes I have done so that
yeah.
people learn from my mistakes and probably you can do better than me. That's the main idea of this webinars.
Absolutely, sir. Also, there is one important sign, flap sign by Dr. Rohit Om Prakash.
Yes, yes.
So if that flap sign is there, that means the Argentinian flag sign, it has occurred, but it has not progressed posteriorly.
Yeah, correct.
So by this step down phaco and soft shell technique, you can complete phaco.
Complete phaco. Only thing is, when you have an Argentina flag sign, as I told you, convert into two semicircular X's.
Absolutely.
Bring the nucleus slightly up. Doesn't matter. Make sure that you have good visco cover for that. And you can do a direct chop technique and try to remove these cataracts. Okay. But very brown, black cataracts, probably I've done it. But the message I want to give everybody is that, especially for beginners and all that, if you have a cataract like that, brown, black cataract, and even Argentina flag sign, that matter, I think you should go and convert into SICS or ACC and get this thing and bail out of the problem.
Absolutely. Keep your ego outside this OT.
Yeah.
Always keep your ego outside your
Because
OT.
I am doing it, I can do. It's not what I want, I am doing, but I want all other people also to practice what is important and what is good for the patient ultimately.
For patient, it doesn't matter whether you had done a phaco or a SICS.
Yes.
If the patient vision is good, patient will be happy.
Absolutely. Correct.
Sir, I have one more question. Like in the videos I have seen sir doing cortical removal after PCR. It was very easy in every case, but I don't find it easy. I find it very difficult to remove the cortex once I have PCR.
Because you're not removed the vitreous. Because you're not removed the vitreous first. Don't be always remove the vitreous first. Then it's very easy to remove your cortical. It becomes very easy, just like your regular regular IA it will become. But if you have vitreous there, what will happen is every time you go inside and try to aspirate the cortex, the vitreous will start coming. And that will block the thing. And every time you pull the vitreous, you're pulling actually on the vitreous base. So you're adding actually more fuel to the flame. And you can have retinal breaks postoperatively, retinal detachment, and all these things. So once you clear up the vitreous, how do you clear up? How do you know clear up the vitreous? Use tricot. Use tricot there and make sure that you clear up all the vitreous. Not only the vitreous is there in the pupil area, go slightly behind the PC tear. Go slightly into the anterior interface also and try to remove the vitreous. And then once you do that, it becomes very, very easy and very. Or you can go through the pars plana as well, as I showed in one of the cases. Only the pars plana for anterior segment surgeon, putting a trocar and cannula may be a little tricky. Since I do both anterior and posterior segment, is easy for me, but you can do that also without any problem at all. Yeah. So you remove the vitreous. So that's the reason. And although you're using bimanual, I suppose. Yeah. You're using bimanual. If you don't remove the vitreous, you'll find it difficult to remove the cortex.
I don't know why the anterior segment, they are quite hesitant to use Kinacote assisted vitrectomy. It works very well and it hardly takes any time and it makes our life much, much easier.
Yes.
So make this habit of this Kinacote
dilute it and use it. And this Kinacote can go into the vitreous and it also takes care of the inflammation because these patients are also prone to CME. All these can, of course. Yeah.
Next day, clear cornea.
Clear cornea. It's also there. It's fine.
And now coming to the pseudo-exfoliation, my experience is that regarding the phimosis cases, when the rhexis size is smaller, if the rhexis size is more than 5.25, I had observed that they don't, the stilt, decentration, that is not there. Phimosis is not there.
Yeah. So what I would suggest is for all patients who got pseudoexfoliation, at the end of the surgery, please assess the capsule-rhexis again. And then put a nick with the vitreous scissors or the micro scissors or whatever it is and try to enlarge the capsule-rhexis. If it's 5, make it slightly more, 5.5 or something like that. And because we don't want the phimosis to occur. The phimosis, it's not only the phimosis. And once the phimosis occurs in pseudoexfoliation, try to yak them as early as possible. Because there can be progressive phimosis and start pulling the zonules and the entire IOL bag complex can go into the vitreous cavity.
And regarding the IFIS cases, forget about the limbal-based incision. Make a little bit anterior incision. Right. And moderation. Always push OVD in moderation. If you push too much of the viscoelastic, then it will again coming outside and outside again and again. So only in moderation.
Yeah. So IFIS can be real, problem on the table. And suddenly, because if you don't take a proper history, and many physicians also don't know, and many patients don't know, because they don't know the relationship between a prostate drug and how the eye, it can affect the eye. So I think you need to ask in the history, look for any pupil which is not dilating, ask the patient whether his patient is having any anti-prostate agents. So the patient may not know, but you should ask them whether they're using any drug for passing urine. So I think that in a common term, if you ask them, then they'll be able to understand. And IFIS, it is better to be safe than sorry, in my opinion, because right in the beginning itself you decide. But halfway through the surgery, putting an iris hook or a malignant ring, it's going to be very, very cumbersome. So in the beginning, you decide this cataract is about grade 4 cataract. I'm having about 6 millimeter pupil, and this grade 4 6 millimeter pupil is going to become 3 millimeter halfway through the surgery. Okay, at that time it's very difficult. So in the beginning itself, I decide I put iris hooks or I put Mulligan ring or BX ring. Now I'm putting the RO. This thing is also there. The RO injector, a little bulky, but still
bulky.
Works.
It's a little bit bulky for me. I tried in one case. Bulky. So Gupta's ring is freely available in India. Gupta's ring, it works very well.
Whatever is comfortable for you.
Yeah,
whatever is comfortable for you, you can do that as well. And but only thing is because you need to make sure that your iris does not come in the way. Because once the iris comes into the way, into the port, it becomes a very messy affair. And I have had some patients wherein I have chewed up the iris and I pushed the iris back and there is a large hole in the iris and I had to put an artificial processes for these patients. So I think it's something which is very, very becoming very common now. Okay. And most of the patients are on Urimax. Even females are on Urimax.
Yeah.
Okay. For urinary retention or whatever it is, they have on Urimax as well. So don't underestimate that. And many of the antihypertensives, some of the antihypertensives, they're all alpha blockers as well. So they can also misbehave like IFIS. Yeah.
Any more questions, Kritika?
Yes, ma'am. So there is a question, sir. There is a question on YouTube platform, and the question is, in case of posterior polar cataract, if we cannot take out the plaque intraoperatively, can we prefer YAG capsulotomy later on,
Yeah, plaque
or
is
instead of posterior capsulotomy?
yeah. If most of the plaques, if the very dense plaques I show you, is it's not very difficult to remove it without damaging the posterior capsule. They can, because there is a small cleavage plane between the plaque and the posterior capsule as well. You just have to put some nice visco there and slide to do something like a visco dissection. And I shown that bimanual technique. You hold just like you remove an ERM from the retina. Similarly, what you do is you also try to hold it with a micro forceps and then try to remove it. And usually there is a small plane which is there, and you can actually do what is called a plaquectomy without any problem, without damaging the posterior calcium. Because if it is a very dense plaque, as I showed the particular case, very difficult to do YAG. Because YAG, you need to have lot of energy for this. Sometimes the YAG will not work also. Or you can do a small posterior capsule-rhexis. Yeah, if because I'm doing a lot of pediatric cataracts, I'm sure Arvind is also doing that. Posterior capsule-rhexis also is possible. And only thing is you have to be a little careful about doing that there. So most of the plaques, you actually remove it without any problem. Mild plaques, you can leave it like that. You can yak them always. Yeah. So only thing is, if the very dense plaques, I try to remove it in the yeah, and without any problem, you can do that.
I agree with sir, because if the plaque is so dense, so this YAG won't work, right?
Yeah.
Yeah.
Very high energy you have to use, and there can be a problem. Yeah.
And then there is IOL pitting and all that other complications.
Absolutely. Yes.
So can we plan a multifocal IOL placement in a case of PCR with a proper anterior vitrectomy done?
Yeah, if PCR, if you are able to do a posterior capsulorhexis, I showed in that particular case, I put an in-focus lens, which is an EDOF lens. So without any problem, you can do that as well. If it's a larger PCR, then I would hesitate to put a multifocal lens. Because in the multifocal lens, I'm not sure, because if it's a larger PCR, whether to put the lens in the bag will be very difficult. It's because the lens may not be there the next day, so you can go drop down depending on whatever support he has got. If it's a smaller PCR, you can convert, but you need to convert into a posterior capsulorhexis.
Yeah, regular.
Don't do that mistake of putting a PCR, putting a lens in the presence of PCR without converting. Okay? Because that is going to extend. When you put the lens, whatever type of lens you put, whatever technique you use, that lens, that PC tear will extend and go to the periphery. And once it goes to the periphery, what the lens becomes unstable. There is no back support there, PC support there. And if not on the table, the next day it may go on go on to the retina, lie on the macula. So I think it's a smaller PC tear, convert into posterior capsulorhexis, and you can do that as well. We have done it we have done in a few cases also. But larger PC tear, like what I've shown you in the PPC, when huge PC tear, it's always better to put a multi-piece lens and lock it into the capsulorhexis margin. So very rarely what I've done is, a few cases, I've put toric lens, and the toric lens, single piece lens, as you know, toric lens, Acrisoft toric, and then we have had rupture of the PC. Okay. So at that time, no, I don't want to explant the lens, already toric lens. So I've done what is called the reverse optic capture. What is the reverse optic capture? The lens the haptic is in the bag. The optic is brought up into the capsular margin. So it's very difficult in a single piece lens, because in single piece there's no angulation. like a multi-piece. There's an angulation, 5 degrees, 10-degree angulation is there in a multi-piece lens. Single piece, there's no angulation. Very difficult, but still it's possible. Because you have no other choice when you have a lens already there and a PC tear has occurred. So, and you can do that as also.
Thank you, sir.
And those two haptics needs to be in the opposite direction of the tear.
Of the tear.
Okay.
So, opposite direction of the tear.
Yeah.
So, yeah, this. Just opposite of the regular optic capture. The regular
Yeah.
optic capture,
Yeah.
the optic is in the sulcus, the optic goes into the bag. Here, the haptic is in the bag, the optic goes into the sulcus. That's called the reverse optic capture. In a single piece lens, I've done it when I put the lens and intraoperatively, suddenly the lens opens up and produces a PC tear. I don't want to explant the lens and patient, and even multifocals I have put like that also.
Yes, sir.
Unmute yourself, Kritika. Unmute yourself.
Hello, sir. Am I audible, sir?
Yeah,
Yes.
yeah.
Yes.
Yes, sir. Thank you for the wonderful presentation, sir. There are no more questions on YouTube platform, sir.
Yeah.
Thank you, sir. Thank you so very much
Thank you very
for
much.
accepting our invitation, and you covered all the complications very well. The
Yeah.
videos were self-explanatory, and you answered all the queries and questions so well.
Thank you very
Great,
much.
sir. Thank you so very much.
It
It was
was
an
a
honor and pleasure to have you here with us. Thank you.
it was a
Thanks.
great learning, sir. Thank you, sir.
Thank you very much. Thanks. All the best to all of you. See you.
Thank you, sir.